So this patient we are planning for lower full arch, severe periodontal bone loss and also severe interproximal decay in molars, and lower anterior has gone already, proclination. There is a periapical lesion close to the mental foramen. So during flap elevation we may have a challenge here. Tissue will be adherent here. We should be careful in the mental foramen area also. So we are planning for a all-on-4 plus additional molar implant. There is a lesion here in molar and premolar, both here in molar mesial root and also in the first premolar root. So the key implant is the tilted implant, usually starting from the second premolar socket. This is the mental foramen, this is the angulation, and from here we will be tilting it mesially to avoid the mental foramen and also its loop. So the challenge here is when we are tilting, it is going through the defect area, the cystic area. So we will see. So during surgery we should be prepared for this challenge. The stability may get compromised. Even if we tilt more anterior, the lesion is continuing. So but the more tilt we are giving mesially, angulation, the more better the situation becomes. So that we can appreciate here. So when we are starting from the second premolar, it actually goes through the defect. So the key is this buccal bone. If this buccal bone is lost during flap elevation or oreoplasty, or the bone is not favorable, then this entire buccal aspect of the implant 5 to 6 mm may be exposed to the socket. So during those time we may have to shift the entire implant into the canine region like this. So this is the challenge, we have to be prepared for this. And coming to the left tilted, first to keep the implant axially in the second premolar. If we see here, on the right side the mental foramen opens in the second premolar area, but on the left side it is little mesial to the second premolar area. Little mesial, it is not in the second premolar, it is mesial to the. So the more the mental foramen is anterior, the more it is unfavorable for us. The more the mental foramen is distal, the more it is favorable for us. So from the second premolar, we are tilting it anteriorly, mesially, and we will see the 360-degree view. It is interfering with the mental loop. So that means we have to tilt some more mesially we have to tilt. So the more mesially we have to tilt to avoid the loop and the mental foramen. Now it is better. This also we can appreciate by keeping the implant totally buccally, labially, and checking in the 3D reformated image. The distance between the mental foramen and the crestal bone is very less here. The lesser the bone between the mental foramen and the crestal bone, the more anterior tilt we have to give, and more mesially we have to start the implant. And we will check the anterior axial implant. The anteriors are quite simple, the bone quality is good. Just mark the midline, and next to the midline we can do the drilling follow the lingual bone, same angulation, lingual wall, like this. Now we have to plant the molar implant. So we will check the first molar area where the cyst is there. Just to check the cystic area, you can see the huge cyst close to the mandible foramen. Hold. And there is root resorption also. So we will see the distal root. Distal root is quite okay. And if you see here, the roots are divergent. But it won't create difficulty during extraction because there is a huge cyst in the root. So better to go towards the 7 area. So in the 7 interdental area we can place along the lingual wall. There is a good bone is there, 8 mm, 10 mm, even a 10 mm implant we can place. So coming to left molar implant, we will check the interdental bone of 6. There is good interdental bone in the 6 region. 8 mm implant we can place, not 10 mm, it is closer. Even in the distal root of 6 we can plant. We will check the interdental bone of 7. It is not very much favorable. Even if you place 8, it is close to the canal. So better to place implant in the either in the interdental bone or in the distal socket, just edge of the distal socket. Slight mesial tilt. 8 mm implant will do fine. The canal is quite closer to the root apex of 8 and 7 and 6. A lot of interdental decay. So the lower challenges are, in a summary, there is a lesion defect close to the mandible foramen, so flap elevation is challenging, and the implant placement we have to deal with this defect, and we have to change the position angulation if necessary. And post extraction of 6 we need to cure it, the lesion. Two lesions are there. Apart from that, no issues.